loud sound while coughing, spasm of the cough followed by vomiting. क्या लग रहा है आपको इससे? थोड़ा सा आइडिया. 15 दिन से खांसी है उसको, 15 डेज से. शुरू में फीवर था इनिशियली, नो एंड बाउट ऑफ कफ. pertussis. So pertussis mostly diagnosed the clinical one. Spasm, they say spasm of the cough followed by the vomiting is there. So how we are going to suspect that this is a whooping cough or this is not other entity? How to confirm it and how to treat it? Okay. What are the other mimics? whooping cough से हमारे जिस टाइप की खांसी होती है, क्या क्या हम उसमें हमें और चीजें जो है इसमें मिलती हैं? देखिए क्या और क्या हो सकता है? अस्थमेटिक, फॉरेन बॉडी, ब्रोंकाइटिस, एलर्जिक ब्रोंकाइटिस, एक्यूट लैरिंगोट्रैकोब्रोंकाइटिस और ट्यूबरकुलर कफ. सो कॉमनली हमें थिंक करना है ना, देन वी हैव टू एक्सक्लूड वन बाय वन थिंग्स. ओके. पेक्युलरिटी क्या है इसमें? pertussis के अंदर क्या हुआ? इज देयर एनी एज प्रेडिलेक्शन फॉर एज? कॉमन किस एज में है ये? हाँ जी. It can happen even in the newborn period. It can happen in infants also. Okay. Children में ज़्यादा common. Even in adult and adolescent, pertussis is common. Although it is underdiagnosed, nobody thinks that it can happen in adult also. Yes. So these are the recent onset, like foreign body, pertussis, tuberculosis we have discussed, and bronchitis. Then airway compression because of the foreign body, anything compressing from the outside, some tumor or some mass is there, and GRD and superiority lung disease like bronchiectasis is also come into this. Okay. Clinical feature below 6 months हो सकता है, हो सकती है. इवन जो है yes, neonatal treatment हो सकता है. Although it is uncommon, but it can happen. Okay. That's why these days इंजेक्शन एक मदर को हम देते हैं प्रेगनेंसी में. कौन सा इंजेक्शन देते हैं? रेजेंट, नो टीडैप, नो टीडी. टीडी में हो गया टेटनस, डिप्थीरिया, और टीडैप देते हैं बिकॉज दैट प्रिवेंट द pertussis इन द neonates. ओके. और कब देते हैं इसको हम? मोस्टली 26 और 36 वीक के बीच में देते हैं मदर को, and it is to given every pregnancy to prevent the neonatal tetanus. Because neonatal tetanus, mostly cases they say they are intrafamilial spread is there. कुछ कंट्री ने तो ये कॉमन कर दिया कि जो जिस घर में डिलीवरी होने वाली है उसके सारे बंदों को टीडैप लगा दो. जो भी पेरेंट्स हमारे पास आते हैं लगवाने, पेरेंट्स जिनके बच्चे यूएसए में जा रहे हैं डिलीवरी के लिए जी, वहां उन्होंने कहा अपने पेरेंट्स को टीडैप जरूर लगवा के आओ. Okay, so this is compulsory in other states. So we should know about this. Severe cases में क्या होता है? ये आपने सब में यूजी में भी पढ़ा, आपने पीजी में पढ़ रहे हो. pertussis के अंदर आई एम नॉट गोइंग अबाउट दिस डिजीज. 3 स्टेजेस कौन कौन सी होती हैं? आप यूजी में पढ़ाया ना आप सबको pertussis की? जल्दी बताओ. pertussis में कटार स्टेज पहले पे है, प्रोड्रोमल स्टेज और कटार स्टेज, देन कन्वर्सन कौन सी आएगी? वो तो लास्ट में आएगी ना. हाँ. फर्स्ट है प्रोड्रोमल, कितने वीक्स तक आएगी? प्रोड्रोमल स्टेज में क्या होगा आपका? कफ, कोल्ड, फीवर, जस्ट लाइक एन वायरल. ठीक है. फिर सेकंड स्टेज आएगी, कफ वाली स्टेज होती है. प्रोक्सिमल स्टेज जो होती है दैट विल लास्ट अबाउट 3 to 4 वीक्स और मोर. ओ कन्वर्सन स्टेज, इसको आप 100 डेज डिजीज भी बोलते हैं. ये मोटी मोटी बातें जो सब डिजीज वगैरह सबको बताते हैं, कॉमन चीज आई एम नॉट डिस्कसिंग. ठीक है. और रेयरली कॉम्प्लिकेशन जो है हेमरेज भी हो सकती है, वायलेंट कफिंग के साथ, सबड्यूल हेमरेज इज नोन इन पर्टिकुलर यूनिट्स, फ्रैक्चर इज आल्सो नोन, सबकंडक्टर हेमरेज इज नोन, रेक्टल प्रोलैप्स इज नोन. So these are the uncommon presentation in units are there. Laboratory diagnosis, simple CBC. CBC में क्या मिलेगा हमारे को? Leukocytosis with lymphocytosis. कितने काउंट्स मिल सकते हैं हमारे को? 15,000 से लेके 1 लाख तक. कई बार उसके डिफरेंशियल में भी आता है ल्यूकीमिया के ये, ल्यूकोमाइड रिएक्शन भी इसको बोलते हैं. ठीक है जी, इतने भी बताए गए हैं. और समटाइम इफ देयर इज सेकेंडरी इन्फेक्शन यू कैन फाइंड न्यूट्रोफिलिया आल्सो. ओके, अच्छा इसमें बोलना ही. ओके 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 ओके. So other tests there which are helpful routinely we are just doing this TLC count, CBC, and the clinical most the diagnosis of pertussis is a clinical diagnosis. Serological test, there is spotty evidence, IgG antibodies against which pertussis, PT. प्रोटेक्टिन जो उसका टॉक्साइड होता है उसके अगेंस्ट एंटीबॉडी होती हैं, वो हम इसके अंदर देखते हैं. और कल्चर इज द गोल्ड स्टैंडर्ड फॉर द ट्रीटमेंट. इसके पर्टिकुलर मीडिया होता है कल्चर का. इसका क्या नाम है मीडिया का? एग्जाम में पूछते हैं एग्जामिनर, यूजी में मुझे पता है, अभी मीडिया का नाम बताओ, इतनी भी पूछते हो. बीजी मीडियम, बोर्डिटेला गेंगो मीडियम, स्पेशल होता है इसका मीडियम. ठीक है, उसके अंदर इसको कर सकते हैं. फेस्टिडियस ऑर्गेनिज्म होता है, वेरी डिफिकल्ट टू ग्रो. एंड देन पीसीआर इज द मोस्ट सेंसिटिव. Then the culture, but mostly our diagnosis depend upon clinical picture. Even the WHO says that the diagnosis is by clinical picture only. Investigation, which I have discussed about, cough less than 14 days, clinical routine laboratory tests like we can find lymphocytosis, leukocytosis, then culture PCR more than 14 days or less than 20 days, RT-PCR. PCR is positive in early stage, in late stage, even all the stages. First weeks 10 days weeks के अंदर हमारा कल्चर पॉजिटिव होता है. ठीक है, बाद में भी उसी है कल्चर इज नॉट पॉजिटिव. If the cough is more than 21 days, then we see for the antibody against PT and or RT-PCR in the secondary cases also. Secondary cases mean those who are infected the other family member also. Antibody testing of different isotype और antigen, जितने इसमें antigen pertussis के अंदर होते हैं उसके against की antibodies का है. Now, what is the treatment for it? Should we give antibiotic or should we not give antibiotic? This will depend upon why not to give or why to give. If we give antibiotic, this will reduce the transmission of the disease to the other person, contact cases. It will decrease or lessen the symptoms of the patients. Okay, and complication also. अगर आपका पेशेंट 3rd वीक में आया आपका, क्योंकि दिस कफ इज वी आर सेइंग 100 डेज, अगर आया 3rd वीक में, 4th वीक में, 5th वीक में आया, तब तक तो सारा कुछ हो चुका होता है. तो नो यूज ऑफ एंटीबायोटिक, यू हैव टू गिव सिम्प्टोमेटिक ट्रीटमेंट. ठीक है, और सिम्प्टोमेटिक ट्रीटमेंट में हम क्या देते हैं इसके अंदर? इज देयर एनीथिंग, एनी ड्रग्स? इज देयर एनी रोल ऑफ स्टेरॉइड? इज देयर एनी रोल ऑफ ब्रोंकोडायलेटर? देयर इज नो रोल. पहले लोग दिया करते थे एड्रेनर्जिक ड्रग दिया करते थे, एट्रोपिन लाइक कंपाउंड अलग देते थे. कि इनसे को थोड़ा बहुत जो है एफिड्रिन टाइप देते थे, बट दे इज नो रोल नाउ, इज सेल्फ लिमिटिंग, बट हियर द चाइल्ड बिकम वेरी वीक बिकॉज ऑफ रिपीटेड वॉमिटिंग. So nutrition, hydration is also very important. You have to look for the complication. He is not developing the complication also. So these are the doses. Erythromycin is the drug of choice, 40 to 50 milligram. Clarithromycin, 15 milligram per kg. But erythromycin and clarithromycin we cannot use below 1 month of age because they call jaundice. Okay. Erythromycin we can give less than 6 months also, more than 6 months also, can be given below 1 month also. Clotrimazole, again it is given, but it is not given in smaller age group less than 2 months. Why? It can cause jaundice also. अगर आपको डोजिंग करनी है तो आप इसकी पिक ले सकते हो एक. So this is the summary. Antibiotic early phase. Erythromycin is the drug of choice. Cough suppressant, bronchodilator, no use. Sportive care, management of contacts, age appropriate vaccination. वैक्सीनेशन कौन सा दोगे इसका आप? कौन कौन से वैक्सीन अवेलेबल है इसके लिए? हाँ जी, इनको बताना डॉक्टर साहब, एग्जाम नहीं हुई है, थर्ड ईयर पीजी भी है. परटूस के लिए वैक्सीनेशन कौन सा है? हाँ जी, डीपीटी. कब कब देते हैं? इम्यूनाइजेशन शेड्यूल नहीं पता आपको? 6 वीक, 10 वीक्स, 14 वीक्स, और उसके बाद बूस्टर, फर्स्ट बूस्टर, एंड देन दो अवेलेबल है, एक होलसेल है जो डीपीटी है और एक एएसएलआर है. ठीक है, दोनों में क्या डिफरेंस है? होलसेल में क्या है? विच वन इज बेटर, होलसेल और एएसएलआर? है जी, वाई? Wholesale is better than ASLR because the antibodies formation, they are robust, they stay for a longer time. Okay, ASLR less reactogenetic, no swelling, less pain, but antibody formation is not that, and the waning of the immunity is early. Although clinical, even the patient get clinical infection with pertussis, they know lifelong immunity. Okay. Similarly, with vaccination also, they know lifelong immunity. Immunity start waning about, let us say, 8 to 10 years in natural infection. In wholesale, about 8 years, and ASLR is less, 5 years. Okay. So, आपने करना है? ठीक है, ठीक है.
So again, another case, Harshad, 2-year-old male. He was having fever for 2 days, cough for 1 day, and noisy breathing for 12 hours. So what is the possibility? Whenever we approach any case, we first see what is the site of disease, and what is the nature of disease. So what is the nature of this disease? Fever, cough, and noisy breathing. So mostly it is infectious, but all fever are not because of infections, and all infections are not because of bacteria. So mostly it is infectious by this history, and noisy breathing. So site of lesion, respiratory tract. By this, it is respiratory tract and infectious. So further detail, there is cough, noisy breathing, and during inspiration. So inspiration, noisy breathing, usually because of stridor, maybe other also, but mostly it is stridor. And other thing, there is change in the cry, seems to be painful. So painful cry, stridor during inspiration, and cough, fever. So now narrow down your diagnosis. So site of lesion is respiratory tract. In respiratory tract also there is near the larynx. Anything? So further we decide what is the site of lesion, whether it is above the glottis or below the glottis. Because symptoms are different, it is different. To narrow down our diagnosis, we think whether it is supraglottic or infraglottic. Supraglottic, there is drooling of the saliva, soft stridor, child is toxic, high fever. So in infraglottic, there is barking cough and significant stridor. And DD may be infraglottic, laryngotracheobronchitis group, diphtheria, foreign body, bacterial tracheitis. Many other may be also. Uh, in supraglottic, peritonsillar abscess, diphtheria, foreign body, retropharyngeal abscess, and epiglottitis. कुछ स्लाइड हाइड कर दिया पहले वाले में स्लाइड और ज्यादा थी इसमें हाइट इसमें कम कर दिया so, so among the above there are other features also. Few slides are hidden. They say that there is croup like symptoms. So this child was having croup like symptom. To differentiate it from the croup, epiglottis, retropharyngeal abscess, and bacterial tracheitis. So retropharyngeal abscess and bacterial tracheitis will be discussed in different lectures by different speakers. Croup and epiglottitis. Croup is gradual onset in few days, whereas epiglottitis is sudden onset. In croup, child is well looking, and in epiglottitis, child is sick. Fever is low in croup, but here is barking loud cough in croup, whereas in case of epiglottitis, cough is minimal. Stridor is harsh in epiglottitis, whereas soft in epiglottitis. Prodromal symptom URI worse at night in croup, whereas there is tripod position, drooling of the saliva in case of epiglottitis. In X-ray, there is stipple sign, inverted V shape of the trachea in case of croup, whereas thumb sign seen of swollen epiglottitis in X-ray. So herself, he is active and playful. He was having loud barking cough and high-pitched inspiratory noises, particularly after coughing and crying. These symptoms are absent during rest, has mild rhinitis. So now your diagnosis is narrowed down and it is in favor of croup. Then whenever we manage a case of croup, we have to assess the severity, because by assessing the severity only we can decide how we manage. To assess the severity, there is a scoring system, Westlake croup score, and there are 5 things are seen. One is the stridor, then retraction, air entry, cyanosis, and consciousness. And we give a score 0 to 5. So if total score is less than 2, it is mild croup. 3 to 5 is moderate croup. And 6 to 11 is severe croup. 12 or more is impending respiratory failure. Less than 2 mild, 3 to 5 is moderate, 6 to 11 is severe, and 12 or more is impending respiratory failure. Another grading system is also almost same, but here are only 4 things are taken. But oxygen saturation is taken in this grading system. But oxygen saturation is decreasing, decrease in case of proofs very late. So it is not a good sign. So Westley score is good. Management of group. So be diagnosed by this scoring system, whether it is mild, moderate, or severe. In mild case, usually we give home management, but dexamethasone is cornerstone of this management of the group. So we should give dexamethasone in all types of the group, whether it is mild, moderate, or severe, along with antipyretics. And we tell the parents when to return. If symptoms are worsening, then they should return. In moderate group, we give hydration. We should admit in case of moderate, we give hydration, antipyretics, oxygen, dexamethasone, nebulized budesonide plus minus. We may or may not give. In case of severe groups, we give hydration, antipyretics, oxygen, dexamethasone, budesonide nebulization can be tried in case of severe groups, and epinephrine nebulized is also used in case of severe groups. In case of impending respiratory failure, if score is 12 or more, it is not in this module, that should be admitted in ICU and managed separately. So steroid in groups, ideally it should be given dexamethasone, oral or parenteral. Dose is 0.6 milligram per kg, single dose, orally or IM. Alternatively, we can give periprednisolone or nebulized budesonide in case of severe proofs. But budesonide should be repeated after 12 hours, whereas dexamethasone should be given single dose. Then adrenaline, it is used in moderate to severe proofs. In moderate plus minus, but in severe proofs it is indicated. So diagnosis of group is clinical, investigations are not much of helpful. We should check the saturation, though falling of the saturation is late sign. In COVID time, we isolate these cases. We should wear our PPE. We can use right now also we can use, but slide is made in 2020. So at that time COVID was there, so it is written. Adrenaline nebulization should be used in case of severe groups. Dose is 0.5 ml per kg, but maximum 5 ml. Then monitor for at least 2 hours. So adrenaline nebulized is effective 2 to 4 hours only. So there is rebound again worsening of the symptoms after 2 hours. So whenever we give nebulized adrenaline, we should monitor 2 hourly. Repeat adrenaline after 2 hours if response is poor. We prepare for airway management if symptoms are worsening, like impending respiratory failure. We may ventilate, we may do tracheostomy in ICU setup. And de-escalate the adrenaline and other things if symptoms are improving. So in mild symptoms, dexamethasone and oral paracetamol. In moderate, we should admit, give oxygen, hydration, paracetamol, steroid, and observe if deteriorating, then we should manage as severe cases. In severe groups, we should admit the child in ICU setups and we manage with dexamethasone, adrenaline, nebulized budesonide, and other things, all supportive measures. Antibiotics are not having any role, but if you are in doubt, you are suspecting tracheitis, bacterial tracheitis, you may use. So thank you for your patient listening. If any query,
सर लाइक एड्रेनलिन का डोज आपने 0.5 ml पर केजी बताया,
yes.
तो जैसे 10 kg का चाइल्ड है तो इट विल कम एज 5 ml.
Yes. So maximum dose is 5 ml, not beyond that.
तो एक्चुअली 1 ml में 1 milligram रहता है, तो we have to break all 5 ml and give
Yeah.
simultaneously.
Yes, maximum, but that is maximum dose.
Then we have to repeat after 2 to 4 hours if required.
Yes.
And sir, dexamethasone we can give oral also, no?
Yeah. Oral, IM, IV, whatever. Yes. Yeah, dexamethasone, it is written in the box that it is effective up to 72 hours. But in most of the cases, after 72 hours, they will improve. Any other query?
स्लाइड मोड पे कर दो इसको, स्लाइड मोड पे कर दो. So next is a other case discussion. The 7-year-old girl, they presented with throat pain, fever of 2 days onset, difficulty in breathing, noisy breathing for last 2 days. When we have taken the history, there was no immunization was done, and there was diffuse swelling of the neck also. So what we are dealing with? Yes, हिस्ट्री इम्यूनाइजेशन की सो कुछ नहीं मिला, डिफिकल्टी इन ब्रीदिंग है, स्वेलिंग है, कॉमन सिनेरियो डिप्थीरिया. इधर से कैच है आपका कि उसको डीपीटी भी नहीं लगा और स्वेलिंग है. So when we have to suspect that this is a diphtheria, how we are going to proceed with the diagnosis, what are the complications, and how we are going to manage such cases and post-exposure prophylaxis. If you see this diagram here, what is this? This is a white grayish membrane here also, okay, and the characteristic of this membrane that grayish white membrane over pharynx or tonsil area, it can extend also, and when you try to take the sample, try to remove it, it bleeds. And in what other condition this membrane they are present? जोर से रहा बोलो. और किस किस कंडीशन में आपको मेम्ब्रेन, एक तो मैंने मॉर्निंग में अभी केस डिस्कस किया था ना, स्ट्रेप्टोकोकल का था उसमें, और अगेन इट वाज इन हो गया, बता दिया, इन्फेक्शियस मोनोन्यूक्लियोसिस. और किस किस कंडीशन में हो सकती है मेम्ब्रेन? ओरल थ्रेश में हो सकती है, थ्रेश के केसेस देखते हैं ना, कोई फंगल इन्फेक्शन हमारा हो गया, इम्यूनो कंप्रोमाइज के अंदर हो गया. लेकिन इस मेम्ब्रेन का डिफरेंशिएट करना कि जब ब्लीड करेगा इसको करने, सो दैट इज कैरेक्टरिस्टिक ऑफ दिस मीन. एज द इन्फेक्शन गोज डाउन इनटू द pharynx and down to larynx also, so there is difficulty in breathing and the sound become muffled. Child is not able to speak itself. So these are the symptoms that, and in the nose there is serosanguinous discharge, bleeding with some discharge, and there is crust formation in the nose. The late presentation, they are complication. मैं इसको रिवर्स करता हूँ. What are the complications of diphtheria? Yes. Late complication, early complication. respiratory involvement is there. Okay, choking can be there. Okay, what else? Cardiac. What is it is called? Myocarditis. It can happen either initially also or even after 2-3 weeks also. What common thing? Neurological complication, polyneuritis, motor polyneuritis, and initially also there can be paralysis of the palate also. Even the vision can be affected. So these late complications, sometimes the patient may present as a myocarditis. Sometimes the patient can present as a polyneuritis. No initial symptom. He can present initial symptom, they are so mild or they were not noticed. Patient land up with this in CHF also, in arrhythmias also, tachyarrhythmia, bradyarrhythmia, even with the this any yes. And when you go into depth of the history, that come and with the test, it turned out to be diphtheria. So bulbar palsy there, palatal palsy, myocarditis, acute motor neuropathy, all these are the complications. How you are going to confirm the diagnosis? First, you have to save yourself from the infection, as we have taken precaution in the COVID. Mask, gloves, PP, before you are taking the sample. You have to tell the pathologist, your lab, I am suspecting, please be careful taking the sample. If the child coughs out, so then there can be spread to the infection. So swab एक खास पर्टिकुलर इसके लिए स्टेनिंग होती है, उसका नाम बताओ. एल्बर्ट स्टेनिंग, वेरी गुड. एल्बर्ट स्टेनिंग डिप्थीरिया के लिए होती है. एक मीडिया का नाम मुझे और बता दो बस. लोफ्लर. और एक और इसके साथ टेलुराइड. वेरी गुड. आपको तो सब कुछ पता है. ये एग्जाम में पूछते थे, मुझे इसलिए याद है, हमारे से पूछा करते थे. तो ये अब है एल्बर्ट स्टेनिंग पे आपको क्या मिलेगा? एक इनका पैटर्न होता है इनका. वेरी गुड. चाइनीज लेटर पैटर्न जो होता है इनके, शार्प एंगल से ये बैक्टीरिया एक दूसरे जैसे चाइनीज लेटर है. ये इसका डायग्नोस्टिक होता है इनका स्मीयर के ऊपर देखने का. और क्या करेंगे आप? एक तो आपने एल्बर्ट स्टेनिंग कर रही है, एक आपने इसको कल्चर के लिए भेज दिया है, और इसका पीसीआर भी कर सकते हैं. ओके. जैसे आपने सस्पेक्ट किया, इमीडिएटली आपने इसको, दिस इज ए लाइफ थ्रेटनिंग सिचुएशन. अगर आप अर्ली ट्रीटमेंट स्टार्ट कर देंगे तो भी इसकी मोर्टेलिटी जो है अबाउट 2% के करीब है. इफ यू डिले बाय 4 to 5 days, 1 week, मोर्टेलिटी गोज हायर 20% और मोर. अगर पेशेंट प्रेजेंट करता है मायोकार्डिटिस से, पेशेंट प्रेजेंट करता है और से मोर्टेलिटी और अक्यूट किडनी इंजरी 100% मोर्टेलिटी होती है इसके अंदर. So early diagnosis, early treatment is the key of the management of the diphtheria. What is the treatment for? हाँ जी, एंटी डिप्थीरिया सीरम ADS. डिफरेंट डोजेज है, डिफरेंट क्या है इसका इमीडिएटली. ठीक है. थ्रोट स्वैब आ गया आपका, एल्बर्ट स्टेनिंग आ गई है, कल्चर आ गया इसका सारा, ये एलिक टेस्ट है, रैपिड एंजाइम एसे. हॉस्पिटलाइजेशन, आइसोलेशन इज मस्ट, जैसे हम कोविड में करते थे. आइसोलेशन है, स्पोर्टिव केयर, न्यूट्रिशन के लिए इसका करना है, और ये सीवीटी के लिए. अगर हमारा लरेंजल फ्रेंजल है और 2 days ड्यूरेशन है तो 20 to 40,000 यूनिट्स, नेजोफ्रेंजल 40 to 60, एक्सटेंसिव डिजीज 80 to 1 लाख यूनिट ऑफ हमारे को एडीएस इसको देना है. इसको एंटीबायोटिक्स, व्हाट इज द antibiotic of choice in diphtheria? Penicillins. Okay. Crystalline penicillin we used to give. Non availability of the penicillin और penicillin allergy में उसके अंदर हम क्या देंगे इसको? पेनिसिलिन की भी हम एक क्रिस्टलाइन होती है, एक प्रोकेन पेनिसिलिन होती है जो लॉन्ग एक्टिंग होती है. क्रिस्टलाइन पेनिसिलिन we have to give 1 lakh unit 6 hourly for 14 days IV. और if it is not available, we can give procaine penicillin, long-acting penicillin, 25,000 to 50,000 units per kg in 2 divided doses intramuscularly. Then, if it is not available, we have to give ceftriaxone 100 mg per kg or erythromycin 40-50 mg per kg. Now come the question of post-exposure prophylaxis. कीमोप्रोफाइलेक्सिस आपको देनी है जो उसके क्लोज कांटेक्ट हैं. लेस देन 6 ईयर के अंदर आपको बेंजाथिन पेंसिल देनी है 6 लाख यूनिट एज ए सिंगल डोज, और we can give erythromycin 40 mg per kg in 4 divided for 7 to 10 days. More than 6 years, the dose become double, 12 lakhs intramuscular single dose, or erythromycin, this erythromycin same 40 to 50 mg for 7 to 10 days. Complication we have discussed: airway local compression, myocarditis, neuro liver, acute adrenal necrosis. एक और किसी बैक्टीरिया में भी होती है एड्रिनल इनसफिशिएंसी एक्यूट, किस में होती है? हाँ जी, मेनिंगोकोक्सी. So aggressive treatment, aggressive diagnosis, prevention of complications, and you anticipate the complication. Isolation is very, very important, and I told you that if the treatment given early, still the complication they are to the tune of about 5 to 10%. So you have to be very careful. Then vaccination. Patient ठीक हो गया, वैक्सीन उसने लिया हुआ है, वैक्सीनेशन करोगे उसका नहीं करोगे? हाँ जी, we will do vaccination. ये जो है इसके अंदर हमारे को पेशेंट में एंटीबॉडी ज्यादा नहीं बनती हैं, प्रिवेंटिव एंटीबॉडी. You will again vaccinate the child. Thank you very much. Yes, sir. Next. नेक्स्ट ले लेते हैं, कोई नहीं, चलो. अब ये एक केस सिनेरियो है. 3-year-old गर्ल, फीवर, कफ, rhinitis of 4 days duration. Fever is high grade for last 2 days. Drooling and refusal to feed for 1 day. Noisy breathing and prefer to lie on her side. What is the diagnosis? The catch is a drooling, refusal to feed, and noisy breathing. क्या हो सकता है इसके अंदर? हाँ जी, ऑब्स्ट्रक्शन है कहीं, सुप्राग्लोटिक ऑब्स्ट्रक्शन है, फीवर भी है, राइनाइटिस शुरू में राइनाइटिस था, कफ कोल्ड था, इसका मतलब देयर इज सम कॉम्प्लिकेशन इज गोइंग ऑन. फ्रेंजाइटिस की हो, टोनाइटिस की हो. ड्रूलिंग जो होती है इसमें देयर इज सम ऑब्स्ट्रक्शन इज देयर, डिफिकल्टी इन ब्रीदिंग, नॉइजी ब्रीदिंग, सम ऑब्स्ट्रक्शन इज देयर. सो व्हाट कैन बी द ऑब्स्ट्रक्शन? एब्सेस हो सकती है. So there can be abscess formation as a complication of either tonsillitis, otitis media, or whatever it is. So it can be a abscess formation. So this is a case of retropharyngeal abscess. It can be parapharyngeal abscess. And when there is fever, sore throat, neck stiffness, or neck pain, there is torticollis also. We have seen the children, they are not able to even tilt the neck and the one side is there. Torticollis, drooling, cervical lymphadenopathy, muffled voice, difficult breathing. So from these symptoms, we can see that we are dealing with some obstruction with the inflammatory cause that can be a retropharyngeal abscess. Now X-ray. Are we getting some help in the X-ray? X-ray में हमें क्या क्या मिलेगा इसमें? कौन सा व्यू करेंगे एक्सरे का। और दूसरा इससे क्या हमारे माइंड में आता है, एक तो आपने रेट्रोफ्रेंजियल बता दिया, और दूसरा और क्या आ सकता है, एक्यूट एपिग्लोटाइटिस, उसमें भी ड्रोलिंग होती है ना, ऑब्स्ट्रक्शन होता है, नॉइजी ब्रीथिंग होती है, फीवर की हिस्ट्री होती है उसमें भी, ठीक है। तो एक्सरे हम लेटरल व्यू करेंगे नेक का, तो दोनों में हमारे को थोड़ा डिफरेंस मिलेगा। इसमें क्या मिलेगा हमारे को एक्सरे के अंदर, लेटरल व्यू ऑफ द नेक में हम बोल रहे हैं रिट्रोफ्रेंजियल, इसमें फेरिंक्स के बैक में कुछ प्रॉब्लम है, और प्रीवर्टिब्रल सर्वाइकल रीजन में, वर्टिब्रा के फ्रंट में, और फेरिंक्स के पीछे सम गड़बड़ इज गोइंग ऑन। और उसमें क्या होगा एपिग्लोटाइटिस में, थंब साइन होगा, ठीक है। तो इस तरह से हम डिफरेंशिएट कर सकते हैं। If you see here, the C2 vertebra, the space has increased. Increase in the space more than half the size of the C2 vertebra. C2 vertebra के size से हम देते हैं डबल हो जाएगा, and this is indicative of the retropharyngeal abscess. Now diagnostic is our CT scan. CT scan with contrast. इसका खास क्या होता है, इसमें एक पैराफ्रेंजियल एब्सेस होती है, एक होती है रेट्रोफ्रेंजियल एब्सेस। जब एब्सेस बनती है उससे पहले हमारी जो हो, और ये एब्सेस हमारी, दिस इज कॉमन इन चिल्ड्रन, यंग चिल्ड्रन 2 year 3 year less than 5 year. Why? Because they are lymph node which are draining the oropharynx, pharynx, other areas, and these lymph node, they are with the passive way, they are start dissolving, their evolution of the lymph node is there. So that's why retropharyngeal abscess we find more common in children below 3 year or 5 year. And these lymph node initially they are not abscess, but pre-abscess formation में क्या होता है, just inflammation ही होती है। तो उसमें रेडियोलॉजिकल पिक्चर में इसमें डिफरेंस होगा, वो एक्सरे में हम नहीं बता सकते, उसके लिए हमारे को सीटी स्कैन और एमआरआई भी करा सकते। एमआरआई से हमें पता लगता है ना उसकी, आई एम नॉट गोइंग टू डिटेल, इन्वर्टेड टीबी, इन्वर्टेड में, वेटेड में लिक्विड है या पस है या स्वेलिंग है क्या है, तो उससे हमें एमआरआई से पता लगेगा। और इस सीटी स्कैन में क्या होगा, ये आप देखोगे, ये वाला रिंग, ये अनाउंसिंग लीजन सीटी स्कैन से, this is the vertebra, in front of the vertebra this is the pharynx, or retropharyngeal abscess is there. Now what are the causes of this abscess? Commonly streptopyogenes, staph aureus, they are the main, or anaerobe infection which goes from the oropharynx, even the sinuses. And the antibiotic, we should start the treatment as early as possible, within 24 to 40 hours. एब्सेस का जो फंडा है, एब्सेस हैज टू बी रिमूव। कोई भी एब्सेस कहीं भी होती है ना, हम सर्जिकल ड्रेनेज के लिए बोलते हैं, अर्ली स्टेज में एब्सेस है, एब्सेस नहीं बनी है अभी, वी गिव एंटीबायोटिक। इफ विद एंटीबायोटिक देयर इज नो रिस्पांस एंड देयर इज परफॉर्मेशन एंड द साइज इज एब्सेस इज 2.5 cc है, कम है, इफ इट इज मोर देन वन हैज टू गो फॉर द एस्पिरेशन। ओरल रूट से एस्पिरेशन करते हैं इसकी, ठीक है। सो द ENT सर्जन विल डू इट, otherwise it may burst, it can go into the trachea, it can cause lung complication, it can go into the brain abscess also, it can go to any other region. So this is surgical drainage if the pus size more. Thank you very much. Yes sir. Yes, sir.
Thank you, sir.
Next किसका है? कोई बैठ जाओ, फॉर्म भरने का देना।
Formally march the meeting of RTI.
बैठ जाओ।
I request all the faculties, respected seniors, Come forward for the name tag.
Bansal sir.
Bansal sir, Satish sir, Vikas sir, Yogesh sir, Srikar sir, Gaur sir, Ghanshyam sir.
हाँ भाई। आज तो प्रेसिडेंट है। हाँ ये वो कहाँ गए? आओ सर एमएसवी सर। हाँ सर फोटो खिंचवा रहे हैं। कौन सर? लीजिए सर। सर चलो सर आदत डाल लो सर। आदत डालो आने की हाँ President. Sir, this one. Come, please. Sir, come this side, sir. All see, curious. It is for you only and honoring a great visionary person who made IIT into a very, very high level. To be frank with you all, what I am today in IIT, what stimulus gave me when I was a state president, he was my national president. He gave a great inspiration. He was a very, very big player. He took IIT to a very high level. That gave me the inspiration. I reached Central IIT at this level up to the level of vice president. Sir, please take it. And that was the golden jubilee year of the IIT. Yeah. See, honoring leaders is to get inspiration. How we were inspired, that is why I do. This is not a honor for him. This is for him. I love you, sir. He has honored me. That photo is there.
Welcome. Now I request Dr. Richa ma'am to please welcome Dr. Satish Sharma sir. I request Dr. Vijay Gupta to welcome Dr. Gemc sir. I request Dr. Pratibha ma'am to please welcome Dr. Singareddy sir. I request Dr. PBRS sir to please welcome Dr. Ajay Gaur sir. Sir, I request Dr. Surita ma'am to please welcome Dr. C.P. Bansal sir. सर आपने तो लाइव तो आप ही की वजह से हो रहा है
Come, sir. Thank you. Senior Vice President.
Let's take a break for tea and coffee and then we start the next session. And first of all,
we have group photo.
photo for everything.
लोग उधर बैठा दो, कुछ नहीं आता तो साथ को पीछे करा।
सर आप लोग
All of it. Come on, please continue. Sir, you see President. Sir.
हाँ सर
कैसे खींचना है तो इधर आ जाओ संदीप आप इधर आ जाओ सर
It will be a 10 minutes break for tea and coffee, then we start the next session. तो थोड़ी देर के लिए लो हो जाता है।
रख दिया मैं
जी सर।
टैक्सी वाले का
वाले कस्टमर हाँ
टैक्सी का बिल लेंगे तो जीएसटी लेना क्या?
मैं ना सर आपको चेक दे दूंगा इतने अमाउंट का तुरंत ही तो आप वो जमा कर
मालूम दो दिन एक और
चार्ज करना है
Good. So cystic fibrosis, he can even given as a home treatment. Home treatment. It is a indicator. Why? Because high flow nasal oxygen. This is now whenever bronchiolitis, you are treating as OPD, not improving. Child comes with a red flag sign. You are admitting. You are giving oxygen with a mask. Child is not improving. Next level we are doing. Everybody is doing. HFNC becomes a very modern, because previously HFNC was not there. Every child was intubated, ventilated, which is not needed. But what studies say, HFNC with the bronchiolitis, now everybody is using. Even in our center also we are giving, but they did not. It is only a supportive treatment. It doesn't have any role in reducing the demand of oxygen, or the duration of disease is not getting improved by you are, because child is very sick. Child, you are giving only a supportive therapy. HFNC is supportive therapy, is indicated. It is not a curative therapy. The child has to come out on its own. Till then, we are supporting with HFNC. That's what you should do. So the duration of HFNC, weaning of HFNC, everything depends not with the drug, what the HFNC child is. That's what I wanted to convey you. It might have a role again as a risky therapy to reduce the proportion of children going into, by doing this HFNC. If the child is in the moderate degree, it will improve. Otherwise, you have to put on ventilator and tracheostomy. So many other things may happen. It will begin. CPAP, that is the last level. So before this thing continues, air pass with pressure. It has got, again they say, the limited low quality evidence suggests that breathing improved in children with bronchiolitis who received. Due to limited availability, the effect of CPAP in children with acute bronchiolitis is uncertain. See, what we were thinking, if we give HFNC, we are treated properly. If we give CPAP, we have done that. It is not so, that's what. Of course, these are all important. It can give some improvement. At that time, child will be going for impending respiratory failure. To combat that, it is nothing related to the disease process. That's what I wanted to mention. So, more than that, prevention is very important. So, whatever the basis for bronchiolitis, the incidents to occur, to reduce the incidence of bronchiolitis, you have to make the child very healthy, immunologically competent, because it is a disease of young infant. 1 year, 2 years, not maximum between 6 months to 1.5 years, not more than 2 years and all, rarely. So that is a peak age group. That peak age group is where child should be fed on breastfeeding. The study says if the child is given exclusive breastfeeding 6 months, complementary feeding with extended breastfeeding up to 2 years, the relative chances of getting this is very much reduced. That's what they say. Breastfeeding reduces the incidence of RSV infection and also the lower respiratory infection. So non-breastfed, they have a better this thing. Then of course, COVID taught us, because perhaps that nobody was bothered much, though only ICU people, others will be talking. But we now, pediatrician, everybody started hand washing and other techniques, and passive smoking is certain factors which are aggravating this thing, your bronchiolitis. One, smoking. It is not the child is smoking. If the father is smoking, or in the house where the smoke is more, in a very poor communities where they use the wood and all that for burning or cooking, then that smoke, these things will aggravate, automate dust. So our respiratory people have studied and say that these environmental factors also play a role. And immunologically deficient child who have got a chronic respiratory illness like cystic fibrosis, other primary ciliary dyskinesia, all other diseases can have increased incidence of bronchiolitis. Apart from it, these are all the reasons which you have to prevent. So RSV, this is, it is only, I think I can, for the postgraduates to know, there are immunomodulators drugs is being used, but I have no idea. In fact, I have not used. So my, just what I read, I am telling. As you know, and of course, monoclonal antibodies coming everywhere in rheumatologists and infection disease and others also. They say if you are sure that the child is immunologically not stable in a young infant, when the child will not be immunologically not stable, if it is a preterm, if the child is IUGR, or if the child has got some bronchopulmonary dysplasia, some problem, or chronic lung disease, congenital heart disease, and cystic fibrosis. Like that, if the child have those problems, those as which I already told you, they will be immunologically susceptible child. In those children, the incidence can be reduced by using this monoclonal antibody prior to the onset of infection as a monthly basis. That's what the study says. Indications infants less than a year, like prematurity, CLD, and other reasons they say that. If now another study is Nirsivimab. Another it is, they say if we give a single dose prior to that, it will reduce us the immunity. I think this is all not needed much, but the postgraduate at least you know that there is a monoclonal antibody is there. It can be given as injection on a monthly basis. Those children who are prone to develop bronchiolitis, if it started early, less than a year, the incidence of bronchiolitis can be reduced. This is what it is. So coming to the summary of bronchiolitis, I told very clearly it is a viral etiology, and if it is a mild, if the child is active alert with minimal respiratory distress, you need not do any investigation. You can make it as a home treatment, but when you make a home treatment, you should always warn the parents what are all the red flag signs when they have to report if the child is not improving or if the child is deteriorating. That is in the moderate type, you said the respiratory rate and mild hypoxemia and all that, where you have to admit, give oxygen and eye fluids, adrenaline and all other trials can be done because it is done in the supervision. You are admitting the child. You can give a bronchodilator, if you can try, you can give a epinephrine hypertonic and all that. If the child is not improving, you can do that, but it is not really indicated. But once child has severe, then from the what it has to be shipped to ICU, then you have to give all these things. At the time, investigation can be done ABG because it is needed. How accordingly you have to do other things. This is what how you have to once child improves. If you are intubated, ventilated, gradually you have to wean the child, observe, then you have to discharge. This is what the summary of treatment. Thank you, sir. Thank you. Thank you.
Since morning we are dealing with respiratory tract and we have started with nose coming to throat, then trachea, throat, and then we come to a lung parenchyma. MSV.
थोड़ा सा आगे हो जा.
Oh, sir. Really?
Sorry,
Sir.
sir.
Sorry.
Bronchiolitis, and I'm taking
Sorry,
this
sir.
further and dealing with this community acquired pneumonia. So the learning objective of this 20-30 minute will be that how we can recognize the pneumonia and how we can deal with pneumonia. So whatever I will discuss here, this will be the guidelines of the IAP, and there are so many things which can be the personal opinion or the personal observation of any of the senior pediatrician on the treating the pneumonia, but the mainly we will restrict to the guidelines or the consensus guidelines of the Indian Academy of the Pediatrics. So I think we are teaching the even the health worker also that any child who has come with the cough, cold, fever, and the tachypnea, I think that is the clinical diagnosis of the pneumonia. And the same the IAP is stated that you restrict on that whenever the child comes to you with the fever, cough and cold, and the increased respiratory rate, then you will consider this child as a clinical pneumonia. One thing. Secondly, for that, you should know that what are the various cutoff. Okay, and you know that the WHO has given the cutoff of 60, 50, and the 40, less than 2 months, 2 months to 1 year, and 1 year to 5 year. Then what we will do after 5 year? Okay, because normally what happened that many of the children, or 80 to 90% of the children of the pneumonia, they are coming to us between 1 to 5 year of age, or up to the 5 year of age. So some says, or these module says that if the child is malnourished, particularly the severe acute malnutrition, you can reduce this to the 5, to the level of the 5. Though there is no reference, I have discussed with my colleagues also. So there is no difference. I have reference. I have found that how much you can reduce, but they say that the act of the respiration or the labored breathing, that way. So you have to use your clinical judgment, your clinical acumen for diagnosing the tachypnea. But for the standard therapy, for the standard guidelines, use the cutoff which is given in your textbook, that is a 60, 50, and the 40, less than 2 months, 2 months to 1 year, and more than 1 year to the 5 year of the age. So with this, I will start with this, and the same is the Dev is another child who has come to us. He is a 2 year old child, fever 6 days, cough 5 days, and breathing fast since 2 days. So as a pediatrician, you should know that what is the respiratory rate and what are the findings in the general and the physical examination. But the complaints of the mother itself says that the child is having the fast breathing. So if you see the general examination, the child is febrile, the respiratory is 55, and SpO2 is 95 at room air. Okay. So what you can see here is the, sorry, respiratory rate. है ना? The child is 2 year of age. So ideally, what should be the cutoff of respiratory rate? Yes, है ना? Here is 55. And then when you, and there are no retractions. One more thing that in old books, if you see the subcostal recession, the supraesternal recession, or intercostal recession, nowadays the WHO says that it is the chest indrawing. If the chest is indrawing, that itself, that the chest retractions are there. Okay, so no need for this, and it is the sign of the respiratory distress. In systemic examination, on a systemic examination on auscultation, we have find the reduced air entry in the right infraclavicular area. So these are the finding of this child, 2 year old Dev child. So what could be the possibilities, and how we will clinically approach this child? So again, the possibilities are either it's a bronchiolitis, or it is the pneumonia. Okay, so that is sure, because the SpO2 is also affected, the tachypnea is there. So now there are only two possibilities, and among the infectious cause, that is bronchiolitis, the respiratory infection is most commonly is viral. The pneumonia can be a bacterial one, or you can have a non-infectious cause for this also. So there are two or three possibilities. The first and the foremost important is that this child is developed the pneumonia. The second one is the non-respiratory causes of the tachypnea also. As you know that in the metabolic acidosis, particularly diabetic ketoacidosis, the child may comes to you with the amount of the fever as well as the tachypnea, and the acidosis, and some cardiovascular cause also, as sir has already stated. Then it could be a case of the bronchiolitis or asthma, who is having some superadded infection, and child may run with the fever. So there are mainly three possibilities, but amongst them the pneumonia is more common. Child is 2 year of age, having fever since 6 days, and child is having less SpO2, a high tachypnea rate, and on examination you have find the decreased air entry also in the right infraclavicular area. So these are the WHO guidelines for 60, 50, and the 40. We have already discussed. So now what we can do? Okay, so it's again a triangle for your approach. So first you will confirm. You will confirm the pneumonia. Then look at the severity. If it is a pneumonia, whether the child needs the domiciliary management, the outpatient management, or the inpatient management, that will be decided by the severity of the pneumonia. And the third one is the etiology of the pneumonia. So again, what are the various ways to confirm the pneumonia? What are the various different ways to confirm the pneumonia, or how you will confirm the pneumonia? Chest X-ray. Any other thing? Eh? Danger sign. Danger sign will tell you the severity, and now you have to confirm. So Gracie says that it's a clinical examination. And what else? Some fancy investigations. Bronchoalveolar lavage. That will come, Sunita, under the etiology. Okay, so it's a clinical diagnosis, and VK has rightly said that it's a clinical diagnosis. And see, in many of the cases, this chest X-ray has got no role. Okay, but yes, you are doing it. You are doing it just to know the severity of this, number one, and exact location of the pneumonia, because the tachypnea will tell you that this child is having fever, cough, cold, and tachypnea, so it's a pneumonia. Okay, so it's a basic investigation, first line. So which view you will take? Chest X-ray, which view? PA view. Why not lateral? Eh?
Because in the lateral image, the both lungs almost will be superimposed.
Yes, so lateral view is not a very good angle for diagnosing or confirming the pneumonia. है ना? So that's why we are going with the PA view. So these are two X-rays. You can very well diagnose, very simple one. And on right side, you can see the first one has got a very big pneumonia, and always focus, particularly the JR1, always focus on the trachea also. Okay. So any opacity which you are seeing on the lung parenchyma, always simultaneously look for the exposure, always look for the rotation, always look for the penetration, and always look for the trachea also. To look for the trachea, if trachea is central, it is more in the favor of the pneumonia rather than the effusion. Okay. So come to the community acquired pneumonia, that what exactly the community acquired pneumonia is. Okay, you know that pneumonia is of two types. One is the community acquired pneumonia, and the second one is the hospital acquired pneumonia. So community, for labeling a child that this child is having the community acquired pneumonia, it has got at least four cardinal features. Number one, this community acquired pneumonia occur usually on a previously healthy child. Okay, one thing. Secondly, the child should not be hospitalized in last 14 days in any of the hospital. The second one. The third one, even if he is hospitalized, the child is not hospitalized more than 4 days. Okay, and the fourth one is that the child, yes, these are the three criteria basically. But yes, if the child is already having some prior disease like the severe acute malnutrition or immunodeficient child, or the child in the post measles, so this child is not usually fit under the community acquired pneumonia, because the child is not previously a healthy child. Okay, so this is the definition of the community acquired pneumonia. And again, in hospital acquired pneumonia, you know, it is of the early onset and the late onset, and the day 5 is the cutoff for the early versus the late onset of the hospitalized pneumonia. So how you can classify nowadays, after this WHO classification which comes under 2014, that any child who is having cough, cold, and the child is not having the tachypnea, then child is not having only the ARI or the cough and cold, but no pneumonia. The child who is having the fast breathing and the chest indrawing, plus minus, that the child is having the ARI with pneumonia. And if the child is having some general danger sign, then the child is having the severe pneumonia. So danger sign usually come for detecting the severity of the pneumonia. So what could be the general danger sign? Refusal to feed, yes. Convulsion, yes. High grade fever, severe acute malnutrition, immunodeficiency. Okay, so not able to drink, है ना? Child is so lethargic that child is unable to drink, persistent vomiting, convulsion, lethargic or unconscious, and age less than 3 months, or child with severe acute malnutrition, or in any of the immunocompromised state. So these are the danger sign. So if the child is having any of the general danger sign along with the acute respiratory infection and fast breathing, that child should be inpatient. And this is not a suitable child for treating on the OPD basis. This child should be admitted. So any child having the ARI age less than 3 months should also be admitted in the inpatient rather than treating in the OPD. Okay, how can you grade the severity? The first is the by looking at the general danger sign, by looking at the respiratory rate or the tachypnea, by using the pulse oximeter also at the room air, and by general symptom signs and measuring the functional dearrangement of the lung parenchyma. Okay. So then coming to the etiology, okay, so you have confirmed the pneumonia, you looked at the severity of the pneumonia, that how severe it is, and then you see at the what could be the etiology. So on the basis of the mycobacterial pattern of our country, they have classified the pneumonia as less than 3 months, 1 year, then up less than 5 year, more than 5 year, and in the immunocompromised. So they divided the organism as the more common, less common, and the rare. So if you see that one bacteria, that is the Streptococcus pneumoniae, you will see that Streptococcus pneumoniae is at all the blocks of the etiology of the pneumonia. Even if the child is less than 3 months, between less than 5 year of age, or even if the more than 5 year of the age. So Streptococcus pneumonia and the pneumococci, these two are the main causative organism, bacterial or causative organism for diagnosing or for doing the pneumonia in the children. Then certain other like the viruses, as sir said, it's more common in infancy and in 1 year also, up to 1 year of the age. And some cases you can have the mycoplasma or the respiratory virus more than 5 year of age. In immunocompromised, the pseudomonas, the mycobacteria, the pneumocystis carni, these are the some of the bacteria which are more common if the child is having the some immunocompromised state. Then can you differentiate between the bacterial or the viral? So it is very difficult clinically as well as radiologically also. It is very difficult to differentiate between the viral and the bacterial pneumonia, but there are certain clues. As you know that the viral pneumonias or any viral pathology, it is having the some prodromal symptom. Hai na? So triple C, that is the cough, cold, coryza, and if you want to add the 4C also, that is the conjunctivitis. So 4C, that is the cough, cold, coryza, and conjunctivitis. These are the prodromal in any of the viral illness, so you may get it. And secondly, the child is usually, if you look at the age, the viral infections, the viral pneumonias are more common in infancy, where the bacterial are more common in the older children. Then usually the viral pneumonias children are not having the toxic look or having the toxicity, where the bacterial pneumonias, if the patch is big, if the child is small, then the child is more toxic, looks more toxic. So these are certain signs or symptoms, or certain, you can say, the clues by which you can differentiate between the viral and the bacterial. But it is very very difficult to differentiate in a very 100% manner that this could be clinically, you can say it's a viral or the bacterial, particularly in older children. Then again the same thing, whether the X-ray chest is indicated in all children or not. So usually it is not indicated. It's pneumonia is your clinical diagnosis, but to see the extent, or if the child is not improving, if the child is not improving even with your first line, even if you are in OPD and you write the amoxicillin, the drug of choice, and the child has come to you after 3 days or 4 days and not improving, and if you are seeing that the child is still running with the fever, so you can go for the X-ray to look for the etiology, to look for the patch of the pneumonia. Or if you are not sure about the bronchial breathing pattern or the breathing pattern of the child, or it is the when the disproportionate, the sign and the symptoms are the disproportionate, which is more common in the bronchiolitis, because in bronchiolitis, as sir rightly said, that you will get more symptom, than the sign. Okay, then it is going towards the bronchiolitis. Then the X-ray chest is indicated in such type of the cases. Then other tests like the TLC, DLC, ESR, and C-reactive protein nowadays, again, it is again for your diagnostic purpose, though this will not add too much in the diagnosis of the pneumonia, but yes, definitely they will help you about the progress of the disease, how your child is progressing by acute phase reactant. You can have an eye on this. Then pulse oximeter is really a very good way to see the clinical progress of the child. If the if the SpO2 is less or compromised when you are admitting the child, and if you are taking the continuous SpO2 reading, so this will tell you whether your child and parenchyma or oxygenation is improving or not. Okay. Then microbiological diagnosis, you know that the cultures are taking too much of the time. But yes, again, it is of theoretical purpose, or again, if your child is not improving, or if when you are suspecting some atypical organism, or if for the some medico legal or documentation purpose, even if you want to see that what virus has caused this pneumonia, then you can go for any of the microbiological, right from the throat swab gram staining to the throat swab culture or to the sputum, or if it's you are suspecting that mycobacteria can be there, then the CBNet, or if the viral etiology is there, then you can go for the biofire panel also for detecting or to isolate by the PCR method the virus. Okay, so again it depends on the that what is your aim or objective for confirming the microbiology. So coming to the treatment or choosing the antibiotics, again, you know that these organisms are more common in this age. So first you see the age of the child, then you decide whether you are doing the domiciliary treatment, the outpatient treatment, or your child is admitted with you, or then you will see that whether you are getting some sign of the staph or not. You know that staph again, uh, right from the symptoms and sign. If you are getting some sign of the staphylococcal infection, some simultaneously some skin infection or some throat or some nostrils infection, or even in chest x-ray, if you are suspecting, because you know that the pneumothorax, the pneumatoceles, they are more common with the staph etiology, then you can select the one antibiotic which may cover the staph also, until and unless you have confirmed it with some other source. Okay, so again, the considering the staphylococcal is also a very important when you are deciding your objective of managing a child. Okay, then this is the table that IAP has provided, that what is the drug of choice in the treating the pneumonia. Again, less than 3 months, always admit the patient, and even in if you are suspecting the staph, admit this, and then give either the amoxicillin or as a second line amoxicillin, cefuroxime, or if you switch it to the cefodoxime. Whenever you are suspecting the staphylococcal between 3 months to 5 year, again, this combination amoxicillin and cloxacillin, we are not getting it very in a very day-to-day basis or in routine basis. So you can go for the vancomycin, which is the drug of the choice. Though the vancomycin has got a very less coverage on the methicillin sensitive staph. So again, take care of this, and whenever in vancomycin, you can use in the inpatient. Always use in the inpatient. Don't even prescribe it on the home basis. Then amoxicillin is the drug of choice to 30 to 50 milligram per kg per day. Even in this module, it is written that if you start with the 30 to 50 milligram of the amoxicillin in 2 or 3 divided doses, and if you are not getting the response as it is desired, then you can go for even up to the 90 milligram of the amoxicillin in the higher doses. Okay, so again, the so many things that uh, what Dr. Rahul has also suggested, that give one dose of this and all this. So these are one single study in one single center with a very small population of 100 to 101 children. So we cannot prepare the consensus guideline, or we cannot give it as a rule to use this or this. So standard management is just the amoxicillin. The oral amoxicillin is the drug of choice. Then what could be the other choice of giving the antibiotic? And this is the Infectious Disease Society of the America, IDSA, and the BTS is also, it's a body cellular staph, and one more bacteria is there. So these are the society who have given, or the WHO has given the rationale or the guidelines for prescribing the antibiotics. And again, they are also taking care of the staph, pneumonia, and as well as the H influenzae. See, when we are clinically thinking, so for against the H influenzae we have a vaccine, and because of the government effort, practically all children are immunized against the H influenzae. So always think of the Streptococcus pneumoniae. Okay, so whenever you are thinking of Streptococcus pneumoniae, you will go with the amoxicillin. Okay, yes, you have to think of the H influenzae also. Don't forget this bacteria also. But yes, we have got a very good amount of the protection against the H influenzae in injured children, what the study suggests. So again, the choice is the oral amoxicillin, and these are some of the indication for the hospitalization. As I rightly said, age less than 3 months, SpO2 less than 92% in room air, then marked tachypnea again the more plus 20 to the normal cutoff of that particular age. Then intermittent apnea, grunting, as I rightly said, grunting is a sign of the respiratory distress, not feeding well, dehydrated, or if failed to the OPD management. Okay, so these are certain indication for hospitalizing the pneumonia. Then this is the again the inpatient treatment, that how and when and what you should give. Again, in 3 months, the cefotaxime and ceftriaxone is the, or ceftriaxone is the drug of choice. And then second line is piperacillin tazobactam, or aminoglycoside, amikacin, gentamicin, cefoperazone, sulbactam also you can give. And when you are suspecting the staph, again the first line, again this cloxacillin is we are not getting it, so that's why we are switching over to vancomycin even at this age. 3 months to 5 year, again ampicillin, as it is usually ampicillin is not available alone nowadays, so it is again the choice remains the cefotaxime, ceftriaxone, along with the aminoglycoside, and coamoxilib you can use as a second line. And when you are suspecting the staph, you can go with the either the combination of ceftriaxone with cloxacillin or with the vancomycin. And more than 5 year also the choice is almost same. So if you see the inpatient management also, the choice depends on either the coamoxilib or the cefotaxime, ceftriaxone with one of the aminoglycoside, that is amikacin or the gentamicin. You know that the amikacin is more safe in comparison to gentamicin. So you can we are usually using the combination of the one cephalosporin with the coverage of the one aminoglycoside. Okay, and for staph, it is usually if cloxacillin is not available, so deal staph with the help of the vancomycin. Then macrolides. See, can we use the macrolide as a first line agent? This is the question. So it is very difficult. See what happened, that if you see the resistance, the first line you cannot use the macrolide, because if you compare again with the amoxicillin, oral amoxicillin with the macrolide, the resistance is almost same. of any of the fusion. If you have the facility, first go for the X-ray. Everywhere it is available. But I think in some cases where you are suspecting the effusion is there, so bedside USG is not a very bad choice. I think it's a good choice to go for this. So how this will guide you? How this will guide you? So even if by this USG you have seen it's a clear fluid, no septate, no fibrins are there, or even you have taken it out the diagnostic aspiration and the fluid is clear, but your X-ray says that half of the chest is opacified because of this. So either it's an indication for the chest tube drainage, or it is a time to analyze the fluid also. Okay, but when it is less than 10 mm in USG, so simultaneously you did both the X-ray as well as the USG. So when the USG it is the less than 10 mm fluid is there, or 1/4 to the half of the chest is opacified, then no tap is required. Only by the use of the antibiotics you can dry up whatever fluid is there. So whenever you go for X-ray and USG both, look that what amount of the rim of the fluid the radiologist has given, and what amount or what line is that till this line this is opacified. Then decide whether this child needs the chest tube drainage or not. So pleural fluid analysis, if you have taken it out, you know it is of two types, the transudate and the exudate. You know the usually we are going by the protein of the fluid, we are going with the LDH of the fluid, and then we can go for certain ratios also, the serum glucose along with this and the LDH and all that. 0.5, 0.6, these are the cutoff. But yes, you just remember then what you have to see in the pleural fluid. So right from the color of this, you go for pH, go for cell count. The 10,000 is the cutoff. LDH again more than 1,000 is the cutoff. Sugar less than 40. So whenever you are doing the sugar, always do the serum sugar or the blood sugar also, to look for the ratio of the pleural fluid sugar with the blood sugar. Protein 4 gram is the cutoff, where in textbook the between the exudate and the transudate it is the 3.5 is the cutoff which is given. The microscopy, culture, antigen, pneumococcal antigen, and the PCR. Okay, and whenever you are sending this PCR, or even a lower elder child, if you are suspecting mycoplasma or mycobacterium, you can send the CB net also. But again, the sensitivity and specificity of pleural fluid in detecting the tuberculosis is very less. It is just only 45 to 50%. So don't rely too much on the pleural fluid CB net, okay, for the diagnosing the tuberculosis. But yes, right from the color up to the PCR, you can do various investigation for confirming the diagnosis. So again, the same patient, Dev, he is running with the high grade of the fever even after 48 hours, or chest drainage and antibiotics. Now what you can do? So we can think that this problem may be either the disease related or the drug related or certain complication. So complication may be either the empyema, effusion, or the lung abscess may be there, or you are dealing with certain resistant type of the bacteria, so which is not covered with the ceftriaxone and the cloxacillin, or you can have the drug related, your choice of the drug is not appropriate, dose is not appropriate, or if the thrombophlebitis or drug fever may be a option for you. So if the child is not improving even after all this, you think of that what the problem is. It is the disease related problem, or the condition of the child, or the hospital environment, or the complication, certain complication. So your approach should be the supportive care, oxygen and IV fluid, and think of the complication. You can increase or decrease your approach. So this is the CT chest. Okay. So if you compare it with the USG, the CT chest is almost giving you the same information, but the radiation is too much. In a younger child, if you are sending a child for the CT, and if the pediatric surgeon is not happy with the CT film, and he has ordered that send the child again, even before putting the tube, before removal the tube. So if the child went for 4 times CT chest, you can think of the radiation exposure of that particular child. So same information which the USG has given, even in the CT chest, you can see the amount of the effusion, and on the second side the deposition of the fibrin also. Okay. Then if the fluid is loculated as it was shown in the CT, then your choice is, if it is a small one, you can tap it or you can put the tube. But if it is a large one, then the IAP recommend that you can use the fibrinolytics, or it is a video assisted thoracoscopic surgery, which is commonly known as the nowadays VATS, can be recommended. So if you see the rationality of both, the VATS is not studied in pediatric age group too much. So that's why it's a choice for you. It's a choice for you for complicated cases or where your fibrinolytics are not working. And again, in the fibrinolytics also, streptokinase and urokinase, so there is no study in pediatric age group that which fibrinolytics is better or superior over each other. But the urokinase has got some studies which are documented in pediatric age group. That's why we are preferring to use the urokinase in pediatric population rather than streptokinase. For vets, we don't have any experience in pediatric age group, so this is a choice just for some complicated cases or where the facility is easily available, because it's a more expensive, a skilled person is required for that. So when you use the urokinase, you should instill twice daily for 3 days, and the dose, if the child is around 1 year or above, more than 10 kg, 40,000 unit, and less than 1 year and 10 kg, it is a 10,000 unit, 10 ml, 0.9% saline. And a practical tip that whenever you are using the fibrinolytics by the tube, so after giving this, clamp the tube for at least 3 to 4 hours. Okay, otherwise the fibrinolytics will not work properly, number one. And number two, after injecting this fibrinolytic, the child has a very severe pain also. So manage the pain before using the fibrinolytics agent. So these are two practical tips if you want to use it in case of the effusion or empyema or in loculated effusions. Okay. So what about again antibiotic? The choice and this again depends on the age as well as the etiology and your common antibiotic pattern of your institute. And again for staph, it is the same, the third generation cephalosporin in loculated one. Okay. So the first line, if it is failed, then you can go for Vanco, teicoplanin or IV linezolid. Okay. So sir, pneumonia doesn't end here, sir. Yes, they need MSV, sir. It's the last presentation, I think 4, 5, 6 slide. Oh yes, sir. सर डॉक्टर दास का ऑर्डर है कि 1:30 के पहले हमें फिनिश करना है.
Thank you. After Ajay Garsa's lecture, he made it extensively very clear about pneumonia. Here I want to share. He was with our EB. He was a voracious speaker in EB. And myself and Sugash sir was with my EB. We are very soft in. If sir will talk very nicely and whatever points he raises in EB, that the president has to. It was a very tough time to handle, sir. Yeah, really. Sir. Today he discussed academic also. Today I have the opportunity to listen because I am together with him as a EB member in medical education chapter where he is going to organize a conference here in Gwalior under his leadership. At that time also I will be there, part of it. Thank you, sir. Thank you. Once again, before going to that, I am really happy that the President, Gemc Prajapati sir and Karnesh sir, Secretary, and all who gave me a wonderful opportunity. Coming to the last topic, it's a pre-lunch session. As well, pneumonia never ends from our student days and in future also, because whatever vaccines, whatever other things are there, though the incidence has come down and simple pneumonia has improved, but complicated pneumonias are all occurring. And though the nutritional aspect we have improved, where we are under nutrition, where our days, student days, Bansal sir will accept, we would have seen a lot of kwashiorkor, marasmus, the syndromes, which you people have never had the opportunity. Now you have the malnutrition of obesity and other things. So quickly going to this 18 months old child with high fever, 2 days, grunt, which I already told, breathing difficulty, gradually reduce oral intake. So had fever, rash 1 week back. What what common viral exanthematous fever, which may improve partly, then it will end up in this type of picture. What you can think of, what common viral infection, exanthemat, I gave the clue also because child had fever and rash. Commonly, measles. So measles, pneumonia is one of the very common problem. See, simply now the history tells you the measles would have reduced the immunity, altered the the respiratory pathway. Then the secondary infection could have easily gone. That's the main point. And see the significant chest drawing, reduce entry in the right infrascapular area. Nowadays, it is very difficult in the young infant when the child is agitated, when you auscultate, when there is infiltrations of lung parenchyma, where you could not be able to clearly identify by your auscultation the alteration of the respiratory sound, where the respiratory sounds are muffled, crubs are present, which may not have the typical consolidation as we get. But you should be able to appreciate by your careful examination that it is only identifies that the localization of the part of the lung which has got affected. So here you see just now I was telling about post-measles state, malnourished, rapidly progressive. When, especially in post-measles, when the immunological child is not stable, it will not only be pneumonia, it will go into the pleuropanacamal disease complication. Because why it is important, what could be the common organism, how we have to treat. Initially, I was telling not to use antibiotic. Now you have to use antibiotic rationally, but withholding antibiotic also is a wrong when it is needed. This is what. So first line, as sir told very clearly, ampigenta, second line ceftriaxone and clogs and everything, sir. Apart from the, you have to take care of these things. I am not going. So other complication, necrosis, lung abscess, empyema, which you know. These are all the thing which you can. So last thing, this fever, grunting, and rapid respiratory for 3 days is the right upper lobe pneumonia. Right upper lobe pneumonia, whenever you see, it could be a aspiration pneumonia also, which you have to keep in mind. The definition of recurrent pneumonia, etiology. So I think these are all boring for you. So when you call it as recurrent pneumonia, at least you should have more than 2 episodes in a single year. And other, when you say pneumonia, the classical feature should be there. The common cause, either it can be immunodeficiency and other things, often missed when the congenital anomaly is foreign body, which is large. So it will have a nidus for recurrent infection and CVS sense and adults. And sometimes asthma and other things can be key differentiation. As I already told, upper and lower respiratory involvement, where the lower respiratory involvement, asthma, immunodeficiency, ciliary dyskinesia, only lower respiratory in the aspiration syndromes, anomalies, and these things which you have to do. How you approach, whether it is in the same lobe or multiple lobe, depending on that, you can think for the etiology. If the same lobe is recurrently involved, it could be due to a foreign body lodging that where the organism easily, and again, any tuberculosis also can be as a tumor, or multiple lobe may be due to collapse and other things can be there. So these are all the what other investigative modalities, not only for diagnostic point of view and also therapeutic like bronchoscopy and other things there. So last thing, so we see we have gone in the various headlines which I told, where Satish Sharma sir described very nicely, J.S. Chaudhary sir discussed, and of course sir and myself were discussed the last part, cough with expectation. In this, one important for postgraduates, because in the examination at least you should be knowing this. Without knowing this, you may have, because this PBB, have you heard of this terminology? All of you sure? This is their latest diagnosis, that is protracted bacterial bronchitis. This terminology, and recently, because whenever we talk about chronic suppurative lung disease, for our during our period, there are only two things. One is lung abscess, second is bronchiectasis. Whenever we talk about chronic suppurative lung, in the suppurative lung disease, one more thing is added is protracted bacterial bronchitis. Okay, where you will have significant expectoration. In pneumonia, unless you go for lung abscess or other things, you will not get much of expectoration. Okay, acute pneumonia I'm talking. So how will you recognize? Only few slides. So clinical recognition, because as I told you, it's a relative new syndrome, because appropriate management will make it improve. So we will go with example clinical scenario. This 3-year-old, because it is very common in young age only, below 5-6 years only. So persistent cough, where the instead of noisy breathing, rattly breathing. What do you mean by rattly breathing? It means that there is some liquid, some thing. So when the air goes through the liquid, that means some secretions are there. That is called rattle sound. Initially started with low grade fever, nasal discharge, and child resolved. After that, cough persisted. The fever might not be much, but cough persisted with expectorant. It's called wet cough, means the cough produces some sputum. It's called as a wet cough. When asthma, it will not produce sputum. What other history is needed? So here again, sir has very clearly talked. It can be again maybe a foreign body, for other infection, upper airway infection, or all these things. Asthma. What you have to keep in mind is this PBB as one of the differential. It may be asked as a question also in your theory. Nowadays, we are asking about it. So here, what is very important to differentiate this is there won't be recurrent history normally. Otherwise, child will be having normal growth. There is no predisposing factors, no digital clubbing and chest wall deformity. It means that it is not a, though it is a wet cough, it is not a chronic separate liquid. When there is no clubbing and all that, what does it show? The chronicity is not there. It is relatively acute and shorter duration. No signs of upper airway infection, otherwise normal. So what is the criteria to say PBB? There are three things. One, the child have chronic cough. Acute cough, we'll say within a week or maximum 2 weeks. When it is beyond that, we call it chronic cough. When it exceeds 4 weeks, here cough will be there with expectoration 4 weeks, and lower airway infection can be confirmed by bronchoscopy. And if we give antibiotic for 2 weeks, child will improve. This is what the modified criteria. Why? Because bronchoscopy to do, you do it to a pulmonologist. As a pediatrician, we should be able to diagnose. That's why the clinical diagnosis is chronic wet cough. Again, whenever child having suspected pneumonia treated, or suspected lower respiratory infection treated, but not improving, prolonging for 4 weeks, producing sputum expectoration, one possible diagnosis which you have to keep in mind is PBV. Then why this? Because you have to give antibiotic properly, not stopping antibiotic within a week. Child has partial improvement. If you give 2 weeks proper treatment, child will improve. To confirm the diagnosis, if you have the facility, you can do bronchoscopy. Otherwise, no symptoms and signs of other lower respiratory cause to think. There is no severe pneumonia, no asthma, and other things we are ruling out. Only thing, child had a low grade fever and all that, had cough with expectoration, which is not improving, lasting for 4 weeks, where a clinical diagnosis of PBB should be thought of. That's what. What is extended PBB means? Instead of 4 weeks, it may go beyond that also. Sometimes it can be recurrent. It means that more than 3 episodes can occur per year. This is what. This is a bronchoscopy finding. It is very clear when you put it into that. When it goes in the bronchus, you can see the purulent secretion, which you can aspirate, where with the destruction of the ring of the bronchiole, there will be airway malacia also will be there. That's what the diagnosis there. So this was recently, only 2006 it was came into Brisbane they made, and the common organism are Haemophilus influenza, which are non-typable group, strep pneumonia, moraxella. Sometimes the virus also like adeno, RSV, parainfluenza. The metapneumovirus is one of the very common cause for which can produce secondary. How will you manage? So prolonged course of that is minimum 2 weeks, and the drug of choice is again amoxicillin. As he told, it is only the treatment is only the duration and the diagnosis which has come. That's what the difference. Why? Because you need not do extensive investigation like CT scan and other things and all that needed. Have a suspicion of treat properly, then the child will improve. That's what. So approach to chronic cough more than 4 weeks duration, productive. If there are any finders like cough pointers is there, then accordingly, like any foreign body aspiration, known other immunological factors, then investigate, find out the cause if it is cystic fibrosis or other thing, you can make appropriate treatment. If there are no specific pointers or not there, try to do sputum culture by doing a bronchoscopy, suspect as a PVV, give a proper antibiotic treatment. Then, if the child improves, you leave it. Again, if the child is improving, then again it comes, it can be a recurrent, you can have a recurrent PVV. This is just a more of theoretical interest for postgraduate. But of course, practitioners, we have to have it in mind when the child is not improving within a week time, where otherwise child is active, alert, no fever and all that. It is not a complicated pneumonia. So you should be able to differentiate a complicated pneumonia from protracted bacterial bronchitis. Child will be not be very sick. Child will be having cough prolonged with the sputum, and if you give proper antibiotic, child will improve. This is what. So with this, I am very happy, and once again thank the leaders and the participants. A lot of postgraduates. So we have a feeling that also we have given a lecture to postgraduates, and it is one of the very important module as far as your exam point of concern and practice point of concern. Your day-to-day OPD concern. I thank your professors Ajay Gar sir and others for giving me this opportunity. Thank you.
Thank you, sir.
Oh God.
Before we wrap up, I just want to take a moment to say a big thank you to all these wonderful faculties.
That's up 1:30.
Thank you so much for your time, energy, and all.
Very well, usually it will be extended.
Each session was packed with insight that we can take back and actually use in our clinics.
Oh, sorry, sir.
It was truly a privilege to learn from you. A special thank you to Dr. C.P. Bansal sir for taking the pains to create the YouTube channel, Gwalior Academy of Pediatrics YouTube channel. It's the first time that we are going live. Special thanks to the GSK, our academic grant and support that helped make this entire event possible. And above all, to all the participants for showing up with such enthusiasm and asking great questions and making this workshop so interactive and engaged. But before we conclude, we'd like to take a moment to express our gratitude in a small and a meaningful way. We would now like to present memento to each of our faculties. Like Dr. Sigarelu sir, Donde sir, please give a token of appreciation. Light on कर देना. Light on. Now I request Dr. V.K. Sharma sir to present a memento to Dr. Singarelu sir.
I dedicate all your things to my mentor and
Now I request Dr. P.K. Jain sir to give a token of appreciation, Dr. Ghanshyam Chaudhary, sir. Now I request Dr. K. Sharma, sir, to give a token of appreciation, Dr. Ajay Gaur, sir. Once again, thank you all for being a part of this enriching experiences, and I invite you all for the lunch.